Depression: Cultural Implications in the Hispanic Population by Shannon Guy, Nicole Marrow, and Melissa Stevenson. Depression is an insidious disease. It can strike anyone, anywhere, regardless of ethnicity, income, age, and life situation. Merriam-Webster defines depression as a state of feeling sad, a serious medical condition in which a person feels very sad, hopeless, and unimportant, and is often unable to live in a normal way. People with lasting symptoms of depression, such as persistent sadness, crying spells, loss of interest in daily activities that were formerly enjoyed, either poor appetite or increased appetite with resulting weight loss or gain, anger, a sense of dread or hopelessness, fatigue, and suicidal ideation is considered serious. Depression is treatable with medication, exercise, a nutritional diet, counseling with qualified professionals, and adjuncts such as music, pet, and light therapy. Having depression can cause strain in relationships. It can also cause ineffective coping, reduced efficiency or inability to work, and a profound sense of hopelessness. Our intent for this production is to highlight common and unique issues related to those of the Hispanic community. To get a feeling for what one may experience while depressed, I quote Anonymous, "Depression is such a cruel punishment. There are no fevers, no rashes, no blood tests to send people scurrying in concern. Just the slow erosion of self, as insidious as cancer. And like cancer, it is essentially a solitary experience, a room in hell with only your name on the door." Acculturation to a new country, along with its unique ideas and ways of living, can be challenging. Many can feel alone, isolated, and misunderstood. Imagine going to a strange new place where no one speaks your language. The people dress and express themselves in different ways, eat different foods, and celebrate different holidays. How about navigating to where to go? Street signs are unfamiliar, hospitals and businesses are set up differently, and it can be hard to decide what resources are there to help you. Immigrants and their families deal with these stressors on a daily basis, and becoming acculturated to a new country can mean more positive interactions with others and less daily hassle. But acculturation does not come immediately. It is something that is earned in increments over a lifetime. Having a low acculturation level can contribute to depressive symptoms. Rates of depressive symptoms were originally found to be higher in the Hispanic population versus the non-white Hispanics. According to Stein et al., in 2012, a newer study revealed that Hispanics have comparable rates of depression as any other ethnic group in the population. Aponte Rivera et al. Reported in 2014 that low average socioeconomic status exists among Latino communities throughout the U.S. This leads to disparities related to nutritional status, access to health care, increased stress, and less access to the resources that may be useful. Another factor that affects Hispanic community is an average of lower educational status, less knowledge, opportunities, understanding of conditions and services, and ignorance regarding mental health and ways to treat it affects the type of care one can receive. Among the many frases útiles, useful phrases in español. Here is a collection of some that may be heard when discussing depression. Somatic symptoms and their descriptions may be different with Spanish-speaking patients. There are varying differences of understanding where and how their body is affected by depression. Depressed Hispanic patients may utilize the following terminology when describing how they feel. Nervios. Nerves are often a combination of depressive symptoms, somatic, and anxiety-like feelings. Accompanying symptoms may be trembling, fatigue, malaise, dolor del cerebro, a brain ache, and celajes, hearing noises or seeing shadows. An acute fit of emotions may be described as ataques de nervios. Anger-related symptoms may include bilis, bile, or cólera, rage. Disorders relating to hot and cold may include the terminology pasmo, a chill. Patients may include how they feel about the atmosphere around them and reporting their symptoms as an abnormal circulation of air, mal aire. The patient may speak of having seen a curandero or a native healer for symptoms. Loco, or crazy, is the unwanted stigma attached to mental health issues. It is wise to seek clarification for any terms that you don't understand when working with Hispanic patients. However, prior knowledge of these cultural idioms and terminology may be helpful in building rapport with your Spanish-speaking patients. A specialized cultural assessment is crucial to be able to communicate and understand the needs of Hispanics in regards to depression and healthcare needs. A patient can be asked of the country of origin and date of migration status. Along with the migration status, a discussion regarding to acculturation to the new country is helpful to ascertain how the individual and family are coping. Resources and information can be shared to help with knowledge deficits and how to navigate healthcare. Along with any differing culture, diet can be fundamentally different from the host culture. Preference of foods, availability of resources to buy nutritious foods, and the preparation of foods all contribute to the individual's health, which significantly affects depression. Current research points to deficiency in nutrients and omega-3 fatty acids can contribute to a decreased level of mental health and well-being. Customs, traditions, and beliefs guide a person in every area of personal life. Each of these influence choices that will make to either contribute or to detract from health. Traditions of turning to folk healers, such as curanderos, before going to a medical doctor is common. Hispanics also treat many ailments with folk remedies or herbs. One commonality among most Hispanics is a strong belief in God or a higher power, and the belief that faith and religious adherence is important to one's well-being. It has been said that Hispanics as a whole take a fatalistic view of life, as in the fact of what will be, and that there is little one can do to change one's situation. All of these beliefs affect the way one seeks, receives, and implements health care. Language is a key cultural consideration. What is the native language? What languages are your patients fluent in? Do they need an interpreter to understand basic English or to fully comprehend the medical interventions? What is the basic level of education, and what is the ability to read and write in English and other languages? Interpreters can aid in understanding not only what the healthcare provider is trying to communicate to the patient, but what can be critical for healthcare providers in understanding their patients and not missing key elements of their care. Hispanics are very family-oriented people and generally have close relationships with immediate and extended family. It is important to understand the family makeup, who the decision makers in the family are, and the role that the patient wants the family to take in their care. Hispanic families can provide support in key ways to their members that promotes healing, health, and a feeling of inclusion. In the literature on Hispanics and depression, Luis Fernandez identifies the acronym ESFT, pointing to essential assessment areas. E stands for the patient's explanatory model of illness. Questions that you can be asked to elicit responses regarding the explanatory model are: what does your sickness do to you? How severe is it? How does it make you feel? What kind of treatment do you think you want or deserve? S stands for the social and financial barriers to adherence to treatment. Questions asked are: what is your health insurance situation? Do you have access to a pharmacy? Will you be able to afford treatment? Do you have transportation? Do you have a regular care provider to follow up with? Do you have access to either computer or phone to communicate with your provider? All of these factors can either stand in the way or assist in adhering to the prescribed treatment. F stands for fears and concerns about medication and treatment. Fears and concerns about medications and treatment are common issues patients face, but Hispanics may have cultural, religious, and traditional beliefs that may run counter to the prescribed treatment. Mutual understanding of treatment helps allay fears and concerns. T stands for therapeutic contracting and playback. Negotiating a feasible plan that will be acceptable to the patient is essential if adherence to the treatment plan is expected. Once agreement of the treatment plan has been reached, the patient then verbalizes what the understanding of the plan is to ensure no miscommunication, and the provider can check for gaps in knowledge. Now for some fast facts on Hispanic culture and depression. A recent replication of a depression study indicated that Latinos were not truly at an increased risk of major depression when compared with non-Latino whites. Mexican immigrants have less of a risk of developing depression than do U.S.-born Mexican Americans. Possible causes have been attributed to: acculturated Mexican Americans may feel more deprived than do Mexican immigrants due to various differences in living standards than experienced by those who have immigrated. Most immigrants have very strong family ties, which provide strong familial support and acceptance, and Americanized, U.S.-born and reared children may have less attachment and feelings of security as compared with those who have internalized traditional Hispanic standards. The very first Hispanic Haynes assessment comparing Puerto Ricans, Cuban Americans, and Mexican Americans showed that 6.9% of Puerto Ricans had a greater chance of developing major depression in comparison with the other Hispanic populations. Mexican Americans came in at 2.8% and Cuban Americans at 2.5%. The reasons why this study had these outcomes is not clearly defined or understood. This information came from Luis Fernandez et al. In 2005. According to Ubelacker in 2012, depressed Latinos use mental health services less frequently than non-Latino whites, even when they have health insurance. Once in treatment, Latinos are less likely than non-Latino whites to receive the best available treatments for depression. About 50% of people who receive health care seek it from a general provider rather than a behavioral health specialist. The percentage is even higher for Latinos. Since collaborative care for depression has been shown to provide better health outcomes, an opportunity is provided to improve care through publicizing the benefits of collaborative caregivers when seeking care for mental health services. A focus group study in 2012 was created to reveal attitudes held by Latinos and Hispanics regarding seeking healthcare assistance when having depression. The study was comprised of primarily people who had suffered from depression or who had close family members or friends with depression and participated in their care. Many themes were brought forward that were specific to the Hispanic population. They discussed the importance of seeking help. When a person is depressed, they often isolate themselves from others or pretend to feel okay. When depression continues and is more than just a bad mood or a bad day, professional help is advised. Seeing a doctor and following his or her recommendations puts an individual on the road to recovery and not lingering in suffering. Talking to a counselor also helps sort out problems, helps one learn effective coping skills, and get an outside point of view, directing one to recovery. When depressed, going it alone can lead to serious consequences, including suffering and even death. Attitudes towards these treatments are these. Medications can really help and are positive. There are also strong concerns about the possibility of being addicted to pills. Some felt there were too many pills being prescribed. Medication side effects can be untoward, and weight gain is common with antidepressants. There were common ideas of self-discontinuation of medication treatment instead of following the advice of a physician. Home and folk remedies were used and primarily tried or heavily relied upon. Group treatment for counseling is looked upon as positively for healing. And for healthcare providers, Hispanics had mixed reviews with doctors and mental health providers. Hispanics looked for continuity of care and found it lacking and had multiple negative experiences. The patients preferred coordination of care between physician and mental health professionals. And with telephone-based depression care, there were issues of arranging calls, both with timing and frequency. They felt that phone contact was unreliable and felt that needed interventions did not always take place. With the phone calls, patients felt it was important to know who you are talking to, and all had concerns about who might be calling. Is someone trying to take advantage? Could it be immigration or what? The barriers to mental health care were several and created a potentially large wall to overcome. Culture differences gave a feeling of being misunderstood by care providers, and Hispanics felt that cultural understanding was low or was not adequately dealt with. A social partnership with the physician and a personal connection was highly desired. Without rapport and trust, they did not feel open enough to discuss the intimate and difficult to pursue feelings that were involved. Among the issues of vulnerability, lack of trust was high. Many felt that their information was not secure. They thought that they would be reported to immigration authorities and had clear negative experiences where confidentiality was broken. Examples were given regarding open discrimination and victimization due to ethnic status. Language was also a barrier, as the primary language is Spanish and few to no opportunities to speak via an interpreter being available. Information was not readily available in the native language. When an interpreter is available, there are strong concerns of the accuracy of information being conveyed. Information was also felt to be lacking regarding depression. Many had ignorance and problems with knowledge of depression treatment. The Hispanics discussed the need for public education on depression. Stigma regarding treatment was felt from the community and church, making it uncomfortable or unacceptable to follow through. Concerns about payment, insurance, or the lack thereof, and understanding how the payment systems work were discussed. Disengagement due to the disease of depression leads to minimizing or deflecting the importance or the presence of depression or isolation from others. Many felt the need to manage it on their own. Finally, a duty to family was important. It was felt that others' needs and behaviors could be more important, or it was better to hide depressive symptoms to not trouble the family. Family also could provide immense support, or could be a roadblock and gave judgment regarding treatment. Stigma of being bad, cursed, loco, which is Spanish for crazy, or filled with mal de ojo, evil eye, are concerns for Latinos. Antidepressant treatment is not readily accepted by Hispanics. They may fear the label or stigma of the drug. They don't want to be seen as crazy. They may also not attribute all of their somatic complaints to the overall effects of depression. According to Duval, in 2016, 36% of Latinos receive pharmacological treatment for depression in comparison to 60% of non-Latino whites. Building rapport, education, understanding of the culture, and speaking the patient's language can overcome these boundaries that Hispanic population has with pharmacological treatment. Culturally sensitive treatment is paramount, as some Hispanics are also dealing with immigration and poverty. According to Stein, depressive symptoms in adolescent youth in Latinos come from culturally universal and culturally based stressors. A study was conducted assessing parent-child conflict, economic stress, discrimination from peers, acculturative stress, and attributional style, which is to what the individuals choose to attribute their problems. Latino youth, both males and females, exhibit greater depressive signs and symptoms than any other ethnic group in the U.S. This population demonstrated significant depressive symptoms, with 12% having clinically elevated symptoms of depression and 40% showing subclinical symptoms of depression. Like all populations, females are more likely to have depressive symptoms than males. The acculturative stress that teens experience are worries about immigration, 75%. Having to explain U.S. customs and traditions to parents, greater than 50%. Discrimination, greater than 36%. And financial difficulties, 48%. Some economic difficulty, and 20% more considerable economic difficulties. Results of the study suggested that discrimination and not acculturative stress plays more of a central role in depressive symptoms for Latino youth. Familism had protective effects on moderating the effects of discrimination in Latino youth only when the level of discrimination was low. Those without strong supportive family system did not receive the protective effects. Possible explanations for these harmful effects of discrimination may be attributed to the need for peer support at an adolescent age. Teens are at a critical time of identity formation, when self-esteem and views of the future affected by discrimination may increase depressive symptoms. Like Hispanic youth, the adults have a substantial proven link to perceived discrimination and depressive symptoms. A study among Mexican American adults indicated that positive religious coping, such as faith and working out problems with God or a higher power, had a lessening effect of depressive symptoms when faced with discrimination. However, negative religious coping skills, such as viewing the discrimination as a punishment from God or being abandoned by God, increased the depressive symptoms related to discrimination. The study further showed that both organized religious activities, such as attending church, and non-organized religious activities positively moderated the depressive effects of discrimination. Another finding from this study showed that acculturation is not associated with depressive symptoms, neither changed the effects of perceived discrimination. Older Hispanic adults with low levels of acculturation have been shown to have deleterious effects on mental health. Quag, in 2012, reports findings that depressive effects of acculturation can be lessened by an older person's perceived density of the same ethnic and language backgrounds of others within one's neighborhood. For older adults immigrating with low acculturation status, finding support in an ethnically dense neighborhood can bring feelings of belonging, self-worth, control, and availability of shared knowledge and resources, which leads to the lessening of depressive symptoms. Hispanic older women who have less education and less monthly household income have increased level of depressive symptoms as opposed to Hispanic men. In follow-up treatment for depression, Hispanics have higher rates of early treatment non-adherence for depression. It is critical to carefully plan follow-up care when at a visit for depression. Due to insurance and economic status, patients may be unable to afford medications or afford to continue medical treatment due to cost and challenges in negotiating payment systems. Family burdens, multiple jobs, and transportation problems can make coming to an appointment challenging. Making plans far in advance with periodic reminders can assist with follow-up care. Regular clinical reassessment of progress is needed to evaluate medication effects or problems and to receive collaborative care until health is stabilized. Depression is a disease that is treatable when care is sought for. Helping our Hispanic patients receive the culturally sensitive care needed to find healing brings back meaningful life for one who is suffering. I hope you've enjoyed our presentation. Thank you for listening.